So I am delighted to be here today and to see the impressive number of participants. I think it's 4,300 a minute ago. I have no conflicts of interest to declare, and the talk is about cervical insufficiency and the role of cerclage, and it complements with Vincenzo's presentation. So here is the problem at hand: shortening of the cervix, prolapse of the membranes, and this is the most extreme way, with the membranes protruding through the endocervical canal into the vagina. The condition was first identified in 1678. Is a book entitled The Practice of Physics. And the problem was characterized as the seed is not retained to the womb because the orifice of the womb is so slight that it cannot rightly contract itself to keep in the seed. And incredible as it may sound, in 1678, the cause was identified. Chiefly is caused by abortion or hard labor in childbirth, whereby the fibers of the womb are broken in pieces, one from another, and they and the inner orifice of the womb overmuch slacked. Then in 1865, the name cervical insufficiency was introduced in a paper in the Lancet, and 300 years later, treatment for this elusive condition was proposed. This is Professor Shirodkar, who was in Bombay, India, at the Grant Medical School, who published this paper in a journal called The Antiseptic in 1955. I'm not sure if this journal continues to publish paper. A series of 30 women with at least 4 abortions, some between 9 and 11 weeks, were diagnosed to have a weak cervical sphincter, and it's interesting the choice of words, sphincter, or malformed uterus. And patients confined, the procedure was confined to women in whom he could prove weakness of the internal laws by repeated pelvic examinations. And this is the procedure that Shirodkar introduced that requires an anterior colpotomy, pushing of the bladder, and a knot, and then closure of the colpotomy. Ian MacDonald reported a similar experience in 70 patients from the Royal Melbourne Hospital in Australia. And in essence, the difference was the surgical technique in which no anterior colpotomy was performed. There was a suture, purse string suture, tie, and the simplicity of this procedure has made it popular. Now, the story of cervical insufficiency as an entity has changed because of introduction of ultrasound, as much in obstetrics and fetal medicine. So this is the standard diagnosis with ultrasound. Is a transabdominal scan, the skin over here, bladder, anterior uterine wall. You can see the vagina over here, the cervix, and in this case is something interesting because one of the definitions of cervical insufficiency is cervical ripening, that implies shortening of the cervix. But in this case, there is considerable length of the cervix, which obviously is now very compliant and has allowed prolapse of the membranes into the vagina. This is the equivalent diagnosis. Membranes prolapse into the vagina, cervix is barely visible, and this is a feature that we will discuss in a moment. In extreme cases, the membranes are prolapsed into the vagina and sometimes fetal pods. And you can see here one of our pictures taken by Wesley Lee, in which one can appreciate the lower extremities prolapse into the vagina. Now, in this case, it was possible to reduce the membranes, place a cerclage, and the patient delivered close to term. The condition, visualizing of the membranes, the image after the placement of a cerclage. Now, there are 3 types of cerclages: rescue of emergency cerclage, prophylactic, and a sonographic procedure placed in patients who have a sonographic short cervix who are at risk for preterm delivery. And what I will do in the rest of the talk is review the scientific evidence for the effectiveness of these three types of surgical procedures. So the rescue cerclage is the one that is placed in patients who present with this condition. Membranes are exposed, and this is the McDonald's cerclage. This is courtesy of Karim Kalash in Berlin, Germany, the PRV, and now in Doha, Qatar. Closure of the cervix. Now, the scientific evidence to support the efficacy of this procedure comes really from one small randomized clinical trial published in 2003, in which women who had a cervical length of less than 25 millimeters or the findings of cervical insufficiency, namely loss of cervical mucus, vaginal pressure, and exposure of the membranes, detected with speculum examination. These patients were randomized, and the primary endpoint to cerclage and non-cerclage, and the primary endpoint was preterm delivery at less than 34 weeks of gestation, or compound neonatal morbidity, defined as admission to the neonatal intensive care unit and or neonatal death. So here is the overall design of the trial. Included patients with singleton and twin gestations. All women were given amoxicillin, clavulanic acid, and metronidazole, also antibiotics, and low molecular weight heparin. There was one group randomized to bed rest, and the other group randomized to have a cerclage. And these patients had a cerclage and indomethacin. And these are the number of singletons and twin gestations. All women who were randomized to the bed rest group delivered before 34 weeks of gestation. In contrast, only 53% of women randomized to cervical cerclage plus indomethacin deliver before 34 weeks of gestation. This difference is statistically significant. In coupled also with improved neonatal outcome, you can see that all deliveries occur in the bed rest group before 34 weeks of gestation. But in terms of composite neonatal morbidity and neonatal survival, the composite neonatal morbidity was better in patients who had a cerclage than in those that were randomized to bed rest. Now, the study limitation is, of course, that the bed rest group did not receive indomethacin, but I will say that this is the best evidence available for the efficacy of cerclage that, in my mind, with a small trial, is persuasive and is the best evidence we have today. So the conclusions of this trial is that cervical cerclage is effective in reducing the rate of preterm birth in patients with acute cervical insufficiency, those who present with typical history, a short cervix, and visible membranes, and the patients treated with were prophylactic antibiotics, low molecular weight heparin, and indomethacin, 200 milligrams rectal suppository 2 hours before and 6 hours after cerclage do better than patients with expected management. A technical issue is that the case that I showed you at the beginning of the talk, in which the situation looked hopeless, can be helped by placing a Foley balloon, as described in this figure, this paper published in Obstetrics and Gynecology in 1973. And there are variations in how the membranes can be reduced before the placement of the suture. This is one group, Dr. Song, coming from Korea, using a uniconcave balloon in emergency cerclage. This will be the balloon that is inflated during the procedure, and this is a small movie to illustrate how one can pull in the anterior lip of the cervix, place the balloon, gain cervical length, and then place the purse string suture. Now, the second type of cerclage is prophylactic cerclage, and that is defined as the one placed in a patient with a history consistent with cervical incompetence or insufficiency. This is a systematic review and meta-analysis that includes cerclage in patients who have a history of poor pregnancy performance, and you can see that there is questionable evidence of efficacy. This is the final report of the MRC Royal College of Obstetricians and Gynecology randomized trial of cervical cerclage. This was before the introduction of ultrasound. And in patients who have 3 or more preterm birth and second trimester miscarriages, the placement of a cerclage reduced the rate of preterm birth. Now, after the introduction of ultrasound, there are a number of observational studies that suggest that this may not be required. And let me show you that evidence. Here is an important study that in my mind has not received enough attention. This is the Cervical Incompetence Prevention Randomized Trial, or CPRAC trial. These are 2 papers published in 2000 and 2001. These were women who have a previous preterm delivery, which started with a loss of cervical mucus, premature rupture of membranes without preceding contractions, initial painless dilatation of the cervix, and absent of other possible causes of preterm delivery. And what is interesting about this unique trial is that patients with those characteristics were first randomized to either have prophylactic cerclage at 10 to 12 weeks of gestation or expected management. And women who were allocated to expected management were then followed with cervical lens every 2 weeks, or when symptoms develop, such as, for example, pelvic pressure, the patients were then, if the cervix was less than 25 millimeters before 27 weeks of gestation, they were randomized to cerclage or bed rest. So this design allows really to address 2 questions. One, is cervical prophylactic cerclage effective? And then, is cerclage placed in patients who were expectantly managed and whose cervix shortened effective? So for prophylactic cerclage, these are 44 patients randomized to no cerclage, 23 to prophylactic cerclage, no difference in outcome, suggesting that there is no evidence of efficacy of a prophylactic cerclage. Prophylactic cerclage is the one that is placed only on the basis of a prior history. What about cerclage in the patients whose cervix shortened, who were at risk, but whose cervix shortened during the period of observation? So this will be the group of women who were at risk, who were randomized to expected management in the Netherlands, who were followed and then sub-randomized because the cervix shortened below 25 millimeters before 27 weeks of gestation. And what is interesting in this study is that the outcome was better in patients who had a cervical cerclage, suggesting that it is okay to observe the patient who is at risk and to place the cerclage when the cervix shortened. So this is the conclusion, and I want to emphasize the cutoff of less than 25 millimeters, and the cerclage were placed all the way to 27 weeks, because the practice in many countries is not to place cerclages until 24 weeks of gestation, a practice that is fundamentally concerned with viability. Now, other investigators have addressed the question of whether patients with a history compatible with cervical insufficiency can be observed with serial cervical sonography. Here is a study by Edwin Guzman, Tony Vinceleos, and the group in New Jersey, showing 3 groups of patients when they are followed weekly with ultrasound examinations, the ones that do not shorten the cervix, a group that is an intermediate group that may be called incompetent or insufficient cervix, and the ones that shorten the cervix very quickly. But the message is that dramatic shortening of the cervix in a matter of days, it rarely occurs. Now, an observational study conducted by the same group of Tony Vinceleos and Edwin Guzman were 138 patients who some underwent elective cerclage, so because of history, all of them had a cerclage, and then a group of patients who had the cerclage only if the cervix shortened. And in this figure, it shows that the outcome of these 2 groups is not different. So I believe that this is justification of the best data that we have today, indicating that there is no need to place a prophylactic cerclage, and that one can follow patients serially with ultrasound and place a cerclage if the cervix shortens. What about a cervical cerclage in a patient with a short cervix and a history, and a short cervix defined as a cervix of less than 25 millimeters? This question has been addressed by Vince Verghela, and this is the meta-analysis showing that there is a significant reduction in the rate of preterm delivery before 35 weeks of gestation, and also a reduction in perinatal morbidity and mortality, suggesting in my mind that cervical cerclage reduces the rate of preterm delivery at less than 35 weeks of gestation in patients with a short cervix and a history of preterm birth. But this leads to the question of which, for this group of patients, which was best, cervical cerclage or vaginal progesterone. And we have addressed this question. Agustin Conde, given that there are no head-to-head trials of vaginal progesterone and cerclage, reported an individual patient meta-analysis comparing progesterone and cervical cerclage. And in essence, the results of the indirect comparison is that there is not a difference between the two interventions. But I favor vaginal progesterone as a first line of therapy because this group of patients would not need a trip to the operating room, anesthesia, etc. So vaginal progesterone and cervical cerclage are equally effective for the prevention of preterm birth in women who have a short cervix and a history of preterm birth, but cerclage requires anesthesia and a surgical procedure. Then the last question that I want to address in terms of indication is the patient who has a prior preterm birth despite a cervical cerclage and then gets pregnant. And the question is, what is best? Transabdominal versus transcervical cerclage. And this question has been addressed by the group in London. Is a collaborative group in the United Kingdom, published in the American Journal of Obstetrics and Gynecology in 2020. And in essence, patients with this history were randomized to 3 procedures: a transabdominal cerclage placed before conception or in early pregnancy, a Shirotker, or a McDonald cerclage. And the results, so this is the design of the trial. Patients with a previous failed cerclage, 133, with a late miscarriage or preterm birth between 28 weeks and 14 weeks of gestation, and who had had a low vaginal cerclage, and this trial excluded rescue cerclages. So patients were randomized to transabdominal cerclage, 45 patients, a Shirotka or high vaginal cerclage, and a low vaginal cerclage. And the conclusions of this study were that for this particularly very high group of patients, the rate of preterm delivery at less than 32 weeks of gestation, which was the primary endpoint, was significantly lower in patients who were allocated to a transabdominal cerclage instead of a high vaginal Shirotka and low vaginal cerclage. The number needed to treat to prevent preterm birth in this group, to prevent a preterm delivery at less than 32 weeks, 3.9, or to prevent a fetal loss, 5.3. Now, having discussed the indications of cervical cerclage, let's look at the issue of complications. And the complications are ruptured membranes, vaginal bleeding, the development of subsequent preterm labor, and in some cases, uterine rupture reported with transabdominal cerclage, but also with transvaginal cerclage in some cases. So importantly, infection-related complications have been frequently reported for years. In one study, 18.6% of patients with a cervical cerclage had infection-related complications, and they included septic shock and even maternal death. And this has led to the question of whether these infections are a cause or a consequence of the procedure. So one view is that the primary problem is an untimely initiation of cervical ripening. The cervix becomes compliant, allows the membranes to prolapse to the endocervical canal, and the membranes get to the vagina, are exposed to microorganisms, and then these microorganisms gain access to the amniotic cavity with secondary infection. Of course, there is the issue of placing a cerclage in a patient who already has an infection. Now, the other interpretation is that infection may be the primary problem that leads to the initiation of the mechanisms to lead to expulsion of the conceptus, and this leads to increased cervical compliance and prolapse of the membranes. So what we see clinically is a consequence of an infection. And many years ago, when we were concerned with this, I was at Yale University, we undertook a very simple observation in which in 33 women who were scheduled to go to the operating room, we did an amniocentesis and managed them according to the results of Gram stain. And 51% of patients who had a cervical insufficiency had intraamniotic infection. The most common organisms were ureoplasma and Gardnerella vaginalis. Some patients had Candida and Fusobacteria. Now, the interesting observation was that all patients who had amniotic fluid cultures lost their pregnancy without exception. Among the patients who had a negative amniotic fluid culture, 56% delivered after 34 weeks of gestation. Now, of patients who had a negative Gram stain, which was what we use to detect infection, and who had a positive culture, there were 4 patients who had a cerclage, all lost their pregnancy. They developed clinical chorioamnionitis, and in 2 cases, ruptured the membranes. Now, many times obstetricians are blamed because the membranes have ruptured, and I believe that the reason for this rupture is probably related to the intraamniotic infection and not to the cerclage. All patients who had no cerclage, who had intraamniotic infection, lost their pregnancy. So from that time on, after we made that observation, our practice is to perform amniocentesis to assess inflammation and infection of the amniotic cavity before placing a cerclage, because patients with infection are at risk not only for losing the pregnancy, but also severe maternal complications. Now, those observations are subsequently being confirmed. This is our first study, but you can see that the frequency of intraamniotic infection has been consistently observed and reported to be high. This is the mean reported, 27%, and this is the frequency of intraamniotic inflammation, not surprising, nearly 46%, nearly 50%. Now, the diagnosis of intraamniotic infection, every time that I give these talks, I'm asked, how do we make this diagnosis? The only way to make this diagnosis today is by doing an amniocentesis. These are the tests that we perform. Now, there are rapid tests that can be performed at the bedside. These tests are available in Europe. One is measuring interleukin-6, and this is now, particularly after COVID-19, these tests are quickly available in clinical laboratories. The other one is the one developed by Dr. Yoon, that is the detection of MMP8, and the performance of this test is very similar. This test can be performed at the bedside, and it only takes 10 minutes to perform. And these are the likelihood ratio for a positive result, the sensitivity of MMP8 to detect intraamniotic infection and intraamniotic inflammation exceedingly high. Now, sonographic markers of intraamniotic inflammation and infection is the presence of this material that we have called sludge. Sludge is present and can be detected by transvaginal sonography, sometimes by transabdominal sonography, and this is an example of a patient who had sludge that actually was aspirated. This was done by Juan Pedro Kusanovic. These were the organisms. This is how the material looks like. And the question, of course, is whether intraamniotic infection and inflammation be treated in patients who have acute cervical insufficiency. My view was that this was hopeless because of a number of experimental studies that were done in the past. But I'm going to show you a case presentation, and we'll give you a link for the movie so you can see the details of this case. This is a patient who presented last year to our center. The patient was 20 weeks of gestation and had a cervix short, 73 millimeters in length. So there is a little funnel here, but a short cervix. We performed an amniocentesis, no bacteria in Gram stain, normal glucose, no white blood cells, but the interleukin-6 was very elevated. Now, the patient had been sent home before the results came back, and then the patient comes back. We examine her and see that the membranes are completely prolapsed and there is sludge in the vagina. The 3 options to treat this patient is the conventional cervical cerclage, to give the patient vaginal progesterone and cerclage, to give antibiotics, or a combination of all of them. And the patient didn't want a cerclage. Vaginal progesterone we didn't think was going to work. So we offered the patient antibiotics. We used a combination of cephalosporin, clarithromycin, and metronidazole in the doses that are illustrated there. When the patient was admitted, she was over here. This is the C-reactive protein to indicate that the mother had a systemic inflammatory response. We began antibiotic treatment. The systemic inflammatory response was sustained. There was an elevation in C-reactive protein. Antibiotics were continued for 11 days, and the patient requested discontinuation of antibiotics, and she decided to go home. This is cervical length. remember, this patient did not have a cerclage, and I did not think that this actually could happen, but here is cervical length from 7 millimeters to 21 millimeters. There is a mild funnel there, which I don't know what it means, but you can see that the particulate material that we have seen before had disappeared. Then this is the patient at 36 weeks of gestation, a cervix that has been length and there is no sludge material. And the patient underwent a cesarean delivery at 36 weeks of gestation. A baby 2,500 grams was delivered. There was no evidence of inflammation in the chorioamniotic membranes. You can see that the membranes are clear. There are no neutrophils in the chorioamniotic membranes. So the patient went from having first a short cervix, then clinical acute cervical insufficiency with sludge, was treated with antibiotics, and the patient delivered. And the details of this case are now available in the American Journal of Obstetrics and Gynecology social media channels in Facebook and Twitter, and you can click in this and get more details that I cannot discuss in detail today. Now, is this possible? Well, this paper was published addressing the question whether antibiotic administration in patients with intraamniotic infection who present with cervical insufficiency is effective in reducing and eradicating intraamniotic inflammation and infection. These were women who were cared for at the Seoul National University Hospital in Korea, singleton gestation, have failed cervical dilatation between 16 and 27 weeks of gestation, intact membranes, absence of uterine contractions, confirmed intraamniotic infection and inflammation, were given the combination of antibiotics that I described before, and then there was follow-up amniocentesis. So these are the patients who had acute cervical insufficiency, intraamniotic infection, given antibiotics. We began with 22 patients. Some of them, as should be expected, went on to deliver the 1 week. But there were 16 patients who were undelivered at least for 1 week. Some of these patients had no follow-up amniocentesis. All of them delivered after 34 weeks. But the ones who consented to a second amniocentesis, there were 12 patients. There was resolution of intraamniotic infection and inflammation in 9 patients. And treatment success, defined as a resolution of intraamniotic inflammation or delivery at or after 34 weeks of gestation, occurred in 59% of the cases, suggesting that it is possible to eradicate intraamniotic infection. This was successful in 35%, and the overall treatment success, 59%. So antibiotic administration can be effective in treating intraamniotic infection and inflammation in patients with acute cervical insufficiency, and then these patients, if their cervix has not shortened, they become eligible for the placement of a cerclage. So this is a clinical talk that I wanted to give today. I am delighted and very impressed to participate in a conference on Sunday in which the commitment of obstetrician is shown, and we have over 4,000 people wanting to know about patient management. Kate Bruce, I'm delighted to participate today, and I have great deal of optimism about life. So my last slide is a composite picture that I took at the Fetal Medicine Foundation Congress in Marbella, Spain, a number of years ago when we were doing this in presence. And I want to thank you for your invitation today.
Roberto, thank you very much. You increased the number to 4,600 at the moment. But let me take you through a series of steps, Roberto.
Sure.
Number one, a woman that had a previous preterm birth presumed to be due to cervical incompetence. Is there ever an indication for elective cerclage at 12 weeks?
Yeah, is there ever? I think that those patients can be safely observed. So unless the patient is no compliant patient, I think that I prefer to follow those patients with ultrasound and place as a cerclage is the cervix short.
And even we ignore the MRC trial from several decades ago that defines the number of previous preterm births or late miscarriages.
I believe that we need to accept that the most important advance in obstetrics is the introduction of ultrasound. So the MRC trial is a pre-ultrasound observation. And I think that now we have that tool, we can fine-tune the patient who may benefit. And I think that would be the basis for waiting and placing cerclage only when the patient shortened their cervix.
And when should we start the scans, and how often should we do these scans?
So this is expert opinion. I think that the scans can begin at 13 weeks of gestation. I would recommend scanning the patient, depending upon the magnitude of the risk, every week until, to monitor cervical length, or every 2 weeks.
Okay, and now at 16, 17 weeks, the cervical length is 24 millimeters. Should we do an amniocentesis or proceed with the cerclage?
Yes, I will do an amniocentesis to determine whether there is infection or not. And if there is no infection, I'll go ahead, or inflammation, I will proceed as cerclage. If there is evidence of infection or inflammation, I think that those patients benefit from antibiotic, and then determining whether the infection or inflammation has responded successfully. And then, if necessary, if that is the case, placement of a cerclage, just as we outlined. And this is described in detail in our paper in the American Journal, in which we place cerclage after the patient responds.
So you have clarified the management of these patients in my mind completely. I don't know whether anybody wants to question you at this point. Vincenzo, I don't want us to have a massive overlap with your lecture, but do you want to make any comment to this? It's clear. We get rid of the issue of elective cerclage at 12 weeks, serial measurements of cervical length starting from 13 weeks even, and 25 millimeters or less, amniocentesis first, no inflammation, infection, cerclage, inflammation, infection, the package of antibiotics that Roberto recommended for a week, I presume, and then we repeat the amniocentesis, and now the cervix is 20 millimeters, and then do a cerclage. Is that the story, Roberto?
Yes, that is a great summary. And for those, because I received these questions, I'm going to have a flow chart.
Okay. Shall we now take the woman that just arrived by accident, or hopefully one day at some stage in England or other countries, we introduce routine cervical assessment, let's say at the 20-week scan. Now the cervix is 20 millimeters. Presumably there you hinted at your preference, and I agree, of giving to these women vaginal progesterone.
Yes. So the evidence is conclusive. A patient who has a short cervix, defined as 25 millimeters or less, 24 millimeters, those patients benefit from vaginal progesterone daily. And if that patient, remember that not all women will respond. There are uncontrolled observations to suggest that vaginal progesterone will benefit and reduce the rate of preterm delivery. Patients who continue to shorten their cervix to 10 millimeters benefit from cervical cerclage, because uncontrolled observations suggest that those patients have a rate, if the cervix shortened to 10 and they have a cerclage, 80% of those patients will deliver after 34 weeks of gestation. This paper is also published by a group from the US in the American Journal.
This is very clear again. The second group that will arrive without the previous history, and Vincenzo highlighted through his meta-analysis that these women that are found for the first time to have a short cervix in the absence of the previous history will not benefit from cervical cerclage. Therefore, the primary treatment is progesterone, but you're suggesting that in this group, if the cervix shortens, so we have found this woman at the routine scan at 20 weeks that hopefully had a routine ultrasound scan, the cervix is 22 millimeters, progesterone, review in a week or so, the cervix is stable or above 10 millimeters, carry only the progesterone, less than 10 millimeters, cerclage.
Yes. And for the second cerclage, we also do an amnio before, because for some reason, these patients are not responding to progesterone. And often those patients have intramyotic inflammation and they may benefit from antibiotics. And I want to emphasize that our use of amniocentesis is sort of in contrast to what most people do, who place cerclages without assessing the inflammatory or infectious state of the amniotic cavity.
Vincenzo, do you agree with these suggestions, or do you want to?
Yeah, I will cover, somewhat, some of the subjects on in my lecture coming up. I think amniocentesis is great, but as some people are commenting, and Roberto commented, if the cervix is dilated, then we definitely try to recommend, an amniocentesis. If the cervix is 20, 24, 18 millimeters, the incidence of infection is very low, probably less than 1%, and the incidence of inflammation, it's probably 10% or less. So I think it's important to offer it to discuss it, but I think that the evidence for benefit, it's less obvious. I think we need to be very careful with the woman who's 2 centimeters or more dilated. We do probably all place cerclages on those women. And like Roberto said, they have a very, very high incidence of infection and inflammation. So amniocentesis, I think, should be performed there.
So the rate of infection in patients who have an isolated short cervix is 9%. So
Roberto, is there a sliding scale in relation to the sites?
Yes.
Yeah.
Sure. So if a patient has only an isolated short cervix and one does a speculum examination and the membranes are not visible, the rate of proven infection is 9%. When the cervix is shorter and the membranes are visible, the rate of infection, proven infection, is between 25 and 50%, and the rate of inflammation is even higher. So that is the rationale for it.
But Vincenzo was hinting that there may be a difference in this 9% for somebody with a cervix of 24 versus 15 millimeters.
Well, I believe that is probably the case. The shorter the cervix, the greater the risk of infection. I think that this is correct. And actually, we published this. I have forgotten to mention this. This is in the literature, also in the American Journal. The shorter the cervix, the higher the rate of infection and inflammation, as is the case with sludge as well.
Alfred Abu Hamad.
Yeah, thank you, Roberto and Vince. A couple of clinical questions. A patient comes in on ultrasound, no prior history, and the internal os is open on ultrasound. So there's no functional length of the cervix. Is this a patient directly candidate for a cerclage? And the second question, do you actually pay attention to the rate of change of the cervical length from 1 week to the other? So the patient comes in with prior history of suggestive of cervical insufficiency. At 15 weeks, the cervix is 4.8 centimeters. She comes at 16 weeks and it's 3.1. Is that important to you to change the management? Because sometimes these patients come in a couple of weeks later and the cervix is totally open and the membranes are prolapsed, and that may be associated with a higher risk for infection.
So to the first patient, I take it is a patient who presents with no prior history. One does an ultrasound, and then there is a diagnosis of acute cervical insufficiency and non-measurable cervix, and membranes prolapse into the vagina. That is the patient that I alluded to during the talk, subject to the randomized trial in the Netherlands, in which the cervix is short, membranes are visible. I think that patient is a candidate for a cerclage, and in order to improve management, I think those patients can be offered an amniocentesis to identify infection, because it will be present at the very least in 1 of every 3. And we can give those patients antibiotics and offer a cerclage. Now, Alfred, the second patient.
Is the rate of change of the cervix between 1 week and the other, even though it did not reach the threshold that you would investigate and give vaginal progesterone or consider a cerclage?
Sure. So that question has been addressed by a paper by Vincenzo that is now published in the American Journal just as an early paper. Vincenzo, you want to share your data? Patients who had 24, the patients who present in the mid-trimester with 25 to 29 millimeters.
Yeah, so we scan them, sooner, 25 to 29 millimeters. We usually scan every 2 weeks, people with a prior spontaneous preterm birth. If they get to 25 to 39, they have a higher rate of shortening less than 25, so we should do them in a week. And clinically, Alfred, it's one thing where we write that clinically, if it's 26, we may even do it in 3 days so that they may become candidate for vaginal progesterone and or cerclage, depending on history. I think I agree with Roberto 100%. 25%, it took us 20 years to come to that cutoff. It's just easier to use. You can do all kinds of algorithm and write many, many papers on the rate of change, but it's a lot more difficult to quantify, to use clinically. And another piece of information I wanted to give you that it's also going to be in the great journal is that if a woman, even without a preterm birth, who has a cervix of 10 millimeters or less on ultrasound, 30% of those, 30%, almost 1 in 3, will have an open cervix, and then, like you and Roberto say, will become eligible for physical exam. So I think the clinical correlate, which is an important one, if your cervix is less than 10 millimeters or less, do a speculum or a manual exam, probably both. Make sure she's not dilated.
Thank you.
There are questions, Roberto, about should you give antibiotics in any case? And
Sure.
if the rate is so high, what is the harm of giving antibiotics without needing to do an amniocentesis?
Well, I think that the harm is every time that we implement an intervention in medicine without a good reason, there are complications. So I think the reason to do it is to optimize patient management, to have a method to monitor response to therapy. But in places, if people do not have the skills, the confidence to do an amniocentesis, I imagine that giving antibiotics would be okay, but that is not what I would recommend. If we have people in fetal medicine, I think to do an amniocentesis, I think is the simplest procedure. And I don't see any reason. For the diagnosis of meningitis in clinical medicine, we do a lumbar puncture. This is far simpler than that.
What about in England? I think that hardly anybody would follow you, unfortunately. What about the States, Alfred? Does everybody do amnios there?
No, it's not common to do an amnio. It is quite commonly done for rescue cerclages, patients that present with open cervix and membranes prolapsing. For a short cervix, I think most will not do an amniocentesis before cerclage placement. I don't know what Vince, your thoughts are.
I agree. I agree with Alfred. Go ahead.
Yeah, Roberto, clarify this story of progesterone to the audience, because there is a deliberate misunderstanding, that confusion that vaginal progesterone and 17-hydroxy are the same thing.
So they are not.
Perpetuated by such organizations as the Lancet, for example, recently.
So vaginal progesterone and 17-alpha hydroxyprogesterone caprate are two different compounds. One is a natural hormone and the other one is a synthetic steroid. 17-alpha hydroxyprogesterone caprate is injected as a medication, and there was a time when we thought that 17-alpha hydroxyprogesterone caprate could prevent recurrent preterm birth. That is not the case. And so the evidence today is that in women who have a short cervix, vaginal progesterone prevents preterm birth, 17-alpha hydroxyprogesterone caprate do not. But in addition to that, in women who have a history of preterm birth, there is a very large randomized clinical trial that shows that 17-alpha hydroxyprogesterone caprate does not reduce the rate of preterm birth. So that is the difference between the two. And in terms of the efficacy in patients who have a short cervix, there is one trial, the SCAN trial, specifically designed to examine whether 17-OHPC is efficacious in reducing the rate of preterm birth, and it is not.
And Roberto, the final thing before we move on to Vincenzo is, in a woman that had a previous history of preterm birth, is there a benefit from prophylactic vaginal progesterone or not?
So if a patient only has a history of preterm birth, most of the evidence, our evidence suggests that vaginal progesterone is not efficacious in reducing the rate of preterm birth. Vaginal progesterone is conclusively efficacious in patients who have a short cervix. And I believe that this is easy to understand. There are many causes of premature labor and delivery, and only a fraction of those patients have a short cervix. So if we give progesterone to everybody who has a history of preterm birth, this has not been shown to be effective. There was one trial, Eduardo, published in the American Journal, suggesting it was efficacious, but a very large trial by Brian showed that it's not efficacious. So I do not believe that in patients who have a prior history, neither vaginal progesterone nor 17-HPC are efficacious to reduce the rate of preterm birth.
So the story is quite simple today, Roberto, isn't it? Previous history of preterm birth, no progesterone, no cerclage, serial scans. If the cervix is less than 25, you're suggesting amniocentesis. It seems that most people may not do that. And if the amniocentesis is negative, great, cerclage. And if positive, you advocate and you have shown that antibiotics followed by repeat amniocentesis and then cerclage. Let's leave it at that. We will continue the discussion unless you want to finalize your presentation, Roberto.
Well, I think that we can discuss afterwards. I see many questions here, but we can do that.
Yes. Rasha, did you want to say something extraordinary?
Well, you alluded to what I wanted to ask. I wanted to ask Roberto about whether he recommends that cervical screening should be an integral part of the routine second trimester scan, because, for example, the ISO guidelines, the 2010, they say, quite frankly, that it is not recommended as a routine thing to measure the cervix. And
who says that? Who said that?
The ISO guidelines, the 2010. I don't know. I'm not familiar with any updates later than that, but this is how they say. And for me, in my own practice, I've come across quite a few patients where I just found by accident that they have very short cervix with funneling and so for me, I believe it should be recommended that it should be a routine procedure. I wanted to know whether Roberto agrees or not. You already alluded to that, and you obviously do agree, because of course it's going to increase the rates of the rescue cerclage, and already Roberto has detailed this out in the first part of his talk. That's very important. The other thing I wanted to ask Roberto was, what about twins? Is it going to be exactly the same logarithm of actions and the same methodology, or are we going to lower our guards a little bit?
Rasha, let's agree on the issue of routine cervical assessment. I do that, but hardly anybody else does in England. I don't know whether I want to hear about the States, actually.
So let me clarify the issue. Of professional organizations, the Royal College, the American College, and the SMFM endorse the use of vaginal progesterone in patients who have a short cervix, but they have not endorsed universal cervical length screening. The only professional organization which has is FIGO. Now, what is the evidence? The evidence is that if a woman has a short cervix, defined as less than 25, if we treat with vaginal progesterone, there is a reduction in the rate of preterm birth, a reduction in neonatal morbidity, and every single study of cost effectiveness conducted today show that the universal cervical screening is cost effective. The estimated reduction in cost is for approximately $90 million for every 100,000 women scanned. And the estimate in the United States is that we will save $500 million a year with universal implementation of cervical length and treatment of vaginal progesterone in patients who have a short cervix. So regardless of what professional organizations say, this has been shown to be effective in reducing the rate of preterm birth, reducing the rate of morbidity, cost-effective, and implementation research. When cervical lens is introduced into practice, it also reduces the rate of return burn. And here is a practical issue. If you do not examine the cervix and a patient, sooner or later it's going to happen that someone is going to say, I had a preterm delivery, I have a baby with cerebral palsy, why was the cervix not examined in the mid-trimester? I think sooner or later, the legal system is going to start to come and to say, we deny this patient an opportunity to benefit from an intervention that has been proven to be safe, effective, and cost-effective. So that is the situation in terms of, and I would prefer not to lengthen this, to address the question of twins after Vincenzo's talk.